picture actually
Oh yeah.
taken a while ago. 'Cause I used to work in Virginia, but
Mhm.
yeah, I'm with the UNC network, so that's University of North Carolina. Every state has a university program. Uh, so if you're resident in Georgia, there's a good chance that you can actually get in, and your fee structure is different too compared to coming, from an uh, outside state.
Yeah,
So are we
yeah.
live?
That's a lot of things that you have to like keep in mind of.
Right. So it's 5:27. Are we live yet? Or
Yeah. So we're gonna go ahead and go live.
okay.
Welcome everyone to our January guest speaker with Dr. Baveja. So we'll get started in a couple minutes. So feel free to say hi in the comments.
I'm just gonna wait for you to throw questions at me, okay? And then we'll go from there.
Yeah, so we're just gonna be giving them a couple of minutes to just join and then we'll get started.
Okay.
Yeah.
Welcome Alliance host members to our January guest speaker with Dr. Baveja. Good evening, I'm Madhu. Just to introduce myself, I am one of your sophomore council members, and I'm very excited to be here tonight.
Hey guys, I'm Ritu and I'm one of your committee leaders, and I'm also excited to be here with you guys and have everyone meet Dr. Baveja. So just as a reminder, we are going to have a QR code up for attendance towards the end, so make sure you stay for the entire time.
Before we begin, I'd like to briefly introduce our CTSO/organization to any one of our new members. HOSA is a student-led healthcare organization that strives to prepare students to be the future of healthcare. Through Alliance Academy's HOSA chapter, we bring you monthly guest speakers with a wide range of specialties and from all around the globe.
And now, without further ado, tonight's guest speaker is Dr. Baveja, and on behalf of Alliance HOSA, we welcome you with warm and wide arms. Thank you so much for joining us.
Thank you for having me.
Yeah, we're truly honored. And so we'll start off the discussion and we'll have an opportunity for member questions towards the end. So now the floor is open for anyone who wants to have any questions. You can go ahead and type them in the chat box. So Dr. Baveja, why don't you go ahead and just introduce yourself and give us a little bit of information about your field and your specialty.
So hi, I am a practicing physician. I do internal medicine and infectious diseases. I work at 3 hospitals, actually 4. And so it's been a long journey. Started off in Bangalore, India. Did my MBBS out there, which is a Bachelor of Medicine, Bachelor of Surgery, which is a degree, after doing graduating from college in a science field. And took a path all the way through the UK. Ended up doing those exams. I also have to give credit to my sister, who's also a fellow physician, and she's a nephrologist out here in Virginia. So I kind of followed her path. You tend to follow your siblings, and here in this case, it was a looking up to a an older sibling, and pretty much I honestly wanted to be a veterinarian at one point, and then I kind of ditched the idea and ended up taking care of humans. So And so briefly, yeah, I ended up in New York City. We both did a residency in internal medicine. And then I moved on to do a fellowship at the University of Kentucky in Lexington in infectious diseases and transplant medicine, which is, folks with immunocompromised patients. I kind of worked with them, and then worked in a clinic in Greenville, South Carolina, taking care of both internal medicine and infectious diseases, and also working at a prison system to help with the folks who have diseases more often, related to the prison population with HIV and hepatitis and tuberculosis, and then kind of moved here to Virginia, where my extended family is, sister and her brother, my brother-in-law and her husband, pretty much, who's a rheumatologist, and met my wife, and here I am. So the rest is history, I guess.
Okay, so one thing that I wanted to add was, what is your sister's specialty right now?
So she's been practicing as a nephrologist for almost 13 years. Yeah.
Okay. So what kind of made you shift towards internal medicine and infectious diseases?
So, I mean, the thing is, I just don't want to sit here and tell you, oh, yeah, I like to help out and do this, the usual standard questions, standard answers people actually give. Actually, I was like, to me, it was like, what do I want out of this profession to start with? Why medicine of all things, So, again, it's the achievements, the recognition, the relationships you can build. I guess job security, compensation, leadership, the challenges you meet folks, there's leisure and travel with it. And, on a day-to-day basis, it's challenging. I see very, a wide variety of patients, but right in the beginning, formative years, I have family members who are in the profession, and, obviously, my sister, like I mentioned, was already doing MBBS. And so that kind of gave me a little insight into what it is learning and going through this whole process and going to medical school and kind of shadowing a little bit and seeing. And I used to go pick her up all the way in Bangalore, in Banashankari. It's a city outside Bangalore now, obviously part of Bangalore. So that's how I was molded towards, and, kind of lean more towards medicine than my other interests. I did have other interests as well, but I think it was more like being absorbed into something which was already there, and she kind of set the path for me. So yeah, that was the reason why I wanted to get in. And of course, then the other reasons too down the line, as I've done it for the last several years, the positive impact you have, not just learning for yourself, but also learning for what you can give back to the community. I mean, when COVID hit back in 2020, I was working at this hospital in Goldsboro, North Carolina. So pretty much you have 20, 25 folks with COVID, and you walk in, you wear your PPE, which is your gown and your mask, and you're wearing it for 12 hours and pretty much saving lives and talking to families. And sometimes you lose patients too. And so it was a whole emotional, grueling process. I never thought I would end up in a situation, 9,000 miles away from home, doing this, and was very challenging. So yeah, I guess, but I like what I do. So
yeah.
Hey, Dr. Braveja, I have a question for you. What does a day-to-day look like for you in your profession?
So yeah, the day starts early and ends late. It is a 12-hour job, and it's not, so typically, I'll just be brief. We start early. We do rounds, as they call it. We get a list from the hospital perspective. When you do internal medicine, you get a list of patients, anywhere from 15 to 20 folks, and you cover patients who are admitted from the emergency room to the medical floors. And you've got 3 to 5 floors. You cover a wide variety of patients, right from heart failure to lung diseases to infections to urinary tract problems to end of life care. Have 96-year-old grandma, and no one can take care. She fell, she broke her hip. Now what? So talk to family. Once her hip is fixed, where does she go from here? She has to go to a nursing home. So I coordinate with a case manager. So you have 15, 17 patients. You do your rounds. You obviously go back and look at the chart. We have electronic medical records. You have all the information out there. You come up with a plan, treatment plan, and then it's pretty much like, why did they come in? What are we doing? Where are you going? That's pretty much for every patient. So, and then, yeah, we get a 15-minute lunch break. It's not that great. And then you still get pages and, rapids. I have to go to, we're all ACLS certified. If there's a rapid response, you have to respond. God forbid someone's so-called crashing patient, not doing too well from a respiratory standpoint. You have to make a quick decision, a quick vital thinking. That's the challenging part, like, okay, now which system is not working? Is it the heart? Is it the lungs? What do you do? This patient needs to go to the ICU. You have to pretty much make that big decision about transferring someone to a higher level of care and then coordinating with other doctors. So if there's a patient with internal medicine comes in with a hip fracture, I will talk with an orthopedic doctor. So he will fix the hip. I take care of the other issues, the blood pressure, the diabetes, pain, medications, IV fluids, talking to the family, telling them what the plan is, and communicating with the nurses. And so hopefully if the shift ends well, you end up doing a 12-hour shift. It's called a hospitalist. You work in the hospital. And prior to doing all this, I was working primary care, taking care of patients on an outpatient basis, seeing 20 to 25 folks in Greenville. And this is more challenging. It's more hands-on. You see very sick folks. So that's my typical day. Get done 12 hours. You're out by 7 o'clock. Your pager hopefully stops beeping. You answer all that, and put in all the information you have discussed with patients and family and your plan for the day in a computer system, which we all use now and everybody has access to. And now even families and patients can actually look at their labs and say, oh, if my hemoglobin's dropping, what are we doing about that? Or, you know what, I have an abnormal potassium or abnormal lab, or my thyroid is not working here. It looks like it's off the charts. What are we doing about this? So they actually come by and ask you all these questions. So you have to be mentally prepared walking into that room. There's never a second chance for a first impression. And then, that's the key. You got to have that ability to build a relationship with the patient, the family, and trust. That's the big thing. And also communicate with the nurses. We all speak English, but believe it or not, sometimes the communication is different. They may say something, they may mean something else. Allergies, side effects, the stuff which I get into trouble sometimes communicating like, I take a medication, it tears up my stomach. I never heard of that term. I'm like, what does that mean? Is that a side effect? It tears up your stomach. I'm literally thinking, what do you mean by that? So they were trying to tell me it's more like a side effect. I can have diarrhea or some kind of, complication with these medications. So I think it's very important to spend time and communicate with the patients first, and then the family, and then the care coordinators and the subspecialists who are associated with the patient. So yeah, that's my 12-hour shift. I do 7 days at one place and then get 3-4 days off, and then I work at another hospital. So it's just the typical physician does 7 on, 7 off. So you work 14 days, 15 days a month.
Mm-hmm. And so how does that work? Are you partnered with like certain hospitals that you go to, or you just...
Yeah. I am partnered. What you get is, so once you get done with your education, everything else, you look for a job, you get your contract, and basically you sign a contract with the hospital for a year. And then you apply for privileges. Privileges, you are privileged to work at this hospital and you have to follow their privileges. That means you have to be board certified. You take your exams, after you're done with all this good stuff, pretty much you will be... Let me backtrack a little bit. So what you need to do is you get your USMLE step 1, step 2, step 3. And I guess it's now clinical skills. Once you do all that, then you get into residency. From residency, then you apply and then go from there based on what your interests are, and depending on what part of this country you're interested in, and then pretty much get into a program, and you match to the National Residency Matching Program, NRMP, and then you will be placed into a program and you go from there. And once you're done with all your 3-year residency, depending on what kind of fellowship or residency you're interested in, it's usually 3 years. And unless you do a subspecialty, that's another 2 to 3 years, depending on what you want. For example, ophthalmology, it's another 2 or 3 year a fellowship. ER is, you don't have to do internal medicine. You go straight into ER residency program, and then you get board certified. And now board certification is a big deal. You have to be board certified to get certain privileges in the hospital. They give you, I think, 5 to 7 years before you can actually get into it. You need to be board certified. If you're not board certified, a lot of hospitals do not want you as a doctor. So you have a couple of attempts. And after 7 years, if you're not board certified, you have to go back into a residency 1-year program. So that becomes pretty painful. You're used to a certain lifestyle. You're working as an attending, and now you become a resident. So you're sort of demoted and go back to that lifestyle. So you've got to get board certified and go from there. So yeah.
So we have a question from one of our members.
Sure.
So, what made you switch from working at an outpatient center to a hospital?
So it was an opportunity, yes. Good question, actually. So it was a lifestyle first thing, and second thing is the opportunity. So that's the big thing, the younger folks coming in, you're looking at, okay, great. You're looking at that wonderful stethoscope, and you're like, okay, this is great. I feel very empowered. You're walking the hallways, people are looking at you, and you're like, you feel that power out there. But let me tell you something, very quickly, you tend to realize that you're going to be called for every little thing, several things you're involved with. And, there's a lot of decision making. Okay. So you are responsible for a patient. This is a life. You're not making furniture here. We're dealing with lives. That's how important this is. And there's no second chance. You can just walk into a room and say, I'm sorry, I really messed up. Let's just reboot grandmama and she'll come back. You can just reboot a little button there. She's not a computer. And to you, it's a patient, but to the rest of the family, that's a family member. That's somebody's mom there. So you always have to keep that in mind. And so, yeah, what made me switch? I did it for 3 years. I enjoyed it. It was pretty much 8 to 5, 25 folks, Greenville, South Carolina, for 3 years. And I was like, okay, I'm working 22 days a month here, Monday through Friday. Every other weekend was off. And I was like, I want a lifestyle where I could travel and enjoy the rest of my time and go meet some folks and do whatever. So being a hospitalist now, 7 on, 7 off. And then you have an option to pick up, some more shifts, as they call it. I could pick up somebody's weekend and like, hey, come on in this weekend, we need you. So go by and, work at another hospital for 2 days and just to change. So lifestyle was the first thing. And the compensation too, it's a little different. So.
And kind of like bouncing off of that, I remember as you were talking about your career and your education journey, you mentioned that you worked at a prison facility. I wanted to know a little bit more about what that experience was like and the kind of patients and procedures you would do there.
So it was part of the fellowship. After the fellowship was done, I did a waiver job. And what is a waiver job? So that's for foreign grads. It's when you come on a foreign, visa, your J1 or H1 as they call it, you have to work in an underserved area, which means literally if you're in good standing, there is a shortage of physicians, they will place you in positions around the country where there's a shortage. And so you go work there, and Greenville, South Carolina came up, on my interview list. And when I was looking for jobs, I'm like, okay, something around Virginia, because I had family there. And they're like, you need to work as an outpatient. You're going to take care of patients. And then you're also going to help with infectious diseases and go take care of some folks who will be working or who actually are incarcerated. And then those folks were, with folks, since I had a background in infectious diseases, patients with, or, inmates, as we call them, with HIV and hepatitis and TB. It's pretty rampant. If you have HIV, the risk of you getting TB is 500 times more because your immune system is compromised. And then there's a risk of the kind of folks I actually talked to and took care of had hepatitis or viruses involved with HIV. So HIV is obviously, it was back in the 80s when it was pretty much diagnosed as, gay bowel, and the people were literally dying. But now we have a medication just once a day, and people are now living 20, 25 years from an acute disease and literally a death sentence to now a chronic problem, a chronic disease, just like, cirrhosis of the liver. People are now living 20, 25 years, normal lives, having children, and saying, okay, yes, we may be HIV positive, but we still have a life and a family, and we can give back and teach and educate other folks to prevent this from spreading. I mean, Magic Johnson is a classic example. He's lived with it for so many years, and in the beginning, he was almost spending $1,000 a day on his medication. That's how expensive those medications are. So yeah, going back to the prison system, yeah, we took care of a lot of folks. They would come in, and we would monitor their lab work, make sure they're taking the medications, and then follow their viral load and make sure that the immune system is slowly being boosted and preventing other infections from pretty much taking over the body. So that's how it was, on an outpatient basis, every day for 3 years.
Yeah.
I also had another question, especially when you were talking about like how you saw a lot of people with different types of injuries. What were some of the most memorable cases that you saw in your career?
Oh, it's kind of a whole list. So I can just backtrack a little bit. For the last 2 years, COVID has been, the forefront. And with COVID, we have seen, a lot of co-infections. With COVID, we've actually seen a lot of strokes and heart diseases associated with COVID, and a lot of blood clots. Folks are coming in young, 40 plus, and, they end up with, they said, oh yeah, I got COVID, I didn't take the vaccine. They end up very sick, literally, lungs are filling up with all this fluid, giving them their treatment and medications, and then suddenly here we are now with someone developing a blood clot. So those were pretty challenging. We're like, wow, what is this virus doing? It's so new to everybody, and it's now affecting humans in very different ways. And there was another guy we had who just came in with just tummy pain and belly pain and diarrhea, and he turned out to have COVID. So it's a virus. It can go anywhere. It can affect you in every which way, So it's not only related to your lungs, and you're not going to be coughing and sneezing and saying, okay, this is only related to, like a common cold. So it came in different flavors, and it gave a lot of us new insight into treating and saying, okay, every little patient now coming in, every person coming in with the slightest symptoms, let's just screen everybody. And so yeah, we saw a lot of people with strokes. We saw older folks with some hemorrhages in their brain. We saw blood clots. We saw a few miscarriages. We saw folks who were ultimately very paranoid about taking the vaccine. They were like, this is against my religion. The government is following us. They're injecting us with vaccines and trying to, keep a track of us. I heard all that. I was to go back and I was like, wow, this is amazing how people are thinking through this whole process. And then for me personally, getting, home, I was literally in my basement away from the family and the children so that I wouldn't infect them. So it was a big lifestyle change for me, wearing those shoes and PPEs and the mask for 12 hours and, the face. And it was just, you're getting all these big marks on your face and scars and everything else because of it was a whole lifestyle change because you're just pretty much wearing these masks, and we still have to do that at the hospital. So now it's become, there was a time when you walked into a bank, and if you wore a mask, you would get arrested. Now, if you walk into a bank and you don't wear a mask, they'll look at you like you need to wear a mask. So it's very different. This is the sort of, as they say, the new way of living, I guess. Until I'm not quite sure when this thing is going to go away, but it seems to be coming in waves and in different forms. So
yeah, no, I'm sure that like COVID has like totally like impacted your career in like such a large way.
Right, it did. And in fact, it also affected a lot of people in the medical profession too. The older doctors were like, you know what, at this point, 65, 64, 65-ish, a few of my colleagues and friends, you tend to communicate with a lot of doctors, different age groups, and they were like, I'm done with this. And it was pretty overwhelming. A lot of them actually retired.
Yeah.
And then we had a doctor in the emergency room where I worked, and he passed. Unfortunately, he ended up getting it. He was exposed, and he was not vaccinated, and he died. A lot of nurses have quit too, because it's just very stressful emotionally, going back home and dealing with so many sick folks. So we're actually in a huge dilemma and a vacuum right now to fill doctors and nurses. There are 100,000 positions open for nursing right now. There's a shortage. There's a shortage of physicians too. I mean, you talk to patients when you discharge them from the hospital. I'm like, you need to go see a primary doctor, and they're like, I don't have a doctor. I'm going to go see a nurse practitioner. It's been 3 months since I can even get an interview or an appointment.
Yeah.
So there's a national shortage of physicians and healthcare. It's been pretty challenging.
Mm-hmm. Yeah, and I think a lot of our members that are watching do want to go into the healthcare field in the future. I think that's something that they should like keep in mind of, that there is a shortage and all of that.
Oh yeah.
Yeah.
I mean, I'll kind of sum up it towards the end. I mean, it has a huge, for me personally, a positive impact. You know, what I can do and to help out in my little way, is how I've actually felt good about through all this. Would I go back and do it again? Yeah, there've been a lot of challenges.
Yeah.
There've been times when you have to miss, last minute you make you're planning a vacation or trip overseas, and they're like, hey, we're short. Heart attacks don't just say, okay, will only happen on the weekends or after or before 5 o'clock. There's no working hours for them. It can happen anytime. So you have to learn to readjust and know how to mold your ways and your lifestyle to it. To it's a demanding profession. There's no doubt about it. It is very demanding. So yeah, but that's it's a choice you make and you live with it.
So we have another question from one of our members. So what are some struggles that you had when you were going through your education? Because we all know it's a very long process.
Yes. So struggles, for me as a foreign grad, I guess, so struggles overseas, is that pretty much what the question is directed to? So struggles, for me, it was like, okay, coming to a foreign country, the US with a background from India, so there is no standardization. That's the problem I felt for most foreign grads. So if you do medicine in America, or you are not a so-called foreign grad, you are an American grad, you are at a huge advantage. And the reason is because you could be whatever back home. Nobody knows, okay, the top-notch hospitals, yes, or the universities, AIMS, and some of the big names, KEM in Bombay, and some of these big hospitals people know of, but there is no standardization. So that's the reason they look at your USMLE scores. And my big challenge is I'm not a good test taker. I'm an average guy. I got my scores in the 80s. People were scoring 90 plus. And so yeah, that's the first thing. I'll never forget my personal interview, New York City. I remember we went to these interviews, and the program director out there sat back, and he was talking to me, and he's like, "Oh, your English is pretty good." I said, "Yeah, I come from an English-speaking country. I'm from India. We were a former British colony." And he was like, "Wow, yeah, but it's kind of." He was a little surprised. Tell me about your culture, the background, and all that. And the first question, down the line, as we were talking, he said, "So you don't have a green card. You were not American trained. Your training is overseas. You don't have any experience in America as a physician or like what you guys are doing, observership or learning or in the system." I mean, I was driving on the left side of the road. Even that was a whole culture shock. I'm like, people are driving the opposite way here and using miles, gallons, and pounds. Who uses that? We're the only country in the world using, miles and pounds and gallons. Every other country in the world is using a metric system. So he actually asked me that. He said, "You don't have your green card, your work permit. You've never worked in America, and you got average scores. Why should I take you? The whole world is competing here to get into these residency programs." I remember the sixth interview, I was ready. I said, when I get the job, I will have experience. And that was it. I remember getting a letter 2 weeks later that, you're in the residency program. But what was your struggle, in your education? It is, I wouldn't say it was difficult to get in. The scores are people, you're judged basically by your scores. And you may not be a good test taker. You could be, an average Joe. And in fact, the average folks are doing way better than the ones who are getting 90 and 99 plus. So for a lot of my fellow colleagues, the finances has been a big deal. It is an expensive, tedious process. You're not going to get into any program I've seen on an average. Most folks who I work with, American grads, they have loans anywhere from $300 to $450,000. So that's a huge chunk of money. You're starting your life with a negative balance compared to your other friends, who start early, and engineers can start making money and all that, doing and settle pretty quickly. So it is a marathon. It's not a sprint.
Also, I wanted to know the entire depth thing. Is that like including medical school and residency and everything? Or is it just like med school?
So for most American grads, I talk to a lot of friends, and obviously, you're talking about the debt, right? The money part, the debt. Yeah, that's for resident, for basically for your medical school. Yes. I mean, I have actually somebody from the Georgia area, and he was telling me he's like, there's a difference now. Again, if you're in state and out of state, there's a tuition difference, and I think they all end up in 300 to 350 ballpark figure, somewhere there. So yes, it's not all about money, but let me tell you something. It is important. If you don't have it, that's a problem too, because at the end of the day, we all want careers, and we all want to be well, financially settled too. I mean, the whole idea is here to help and do stuff too. At the same time, there's no free lunch. So there is a cost, and there is a price you pay, and the time is the big thing. Here you keep the time lost, is you will never be able to get this time back. So
Yeah. And one of our members had a question. Do you work along other internists or like hospitalists, or do you have your own like ward of patients?
so I work at the hospital, and so I don't have a private practice. So I do work with other hospitals, so-called fellow hospitalists. We are at one hospital, almost 9 of us. This is in Goldsboro, North Carolina. I work with them. We all, share. I have 18 to 20 workload or patient load. And then, yes, they've got their group of patients they take care of. I got my group of patients I round on. And I don't have a particular ward, but what we have is something called as a geographical rounds. That means I will cover the 7th and 8th floor, rather than running up and down, different floors. So since I have an infectious diseases background, they used to give me the 7th and the 7th floor, and they're like, okay, you need to go take care of these folks who have more infectious diseases problems. So you could take care of folks with patients with COVID.
Mhm.
And so that, yeah, to that sense, but you can't really, we don't, there's no doctor actually who works as a hospitalist has a dedicated ward to himself. It's what they're trying to do right now is, because bigger hospitals, like the other one I worked with was 500-bed hospital in Florence,
Yeah.
South Carolina. So we had 15 doctors rounding, and you have 9 floors. So if you have 3 patients on one floor, 5 on the other, it's just too tedious running up and down different, on the elevators or whatever, trying to get your work done and actually be at these different rooms and family and all that. So they're trying to now stack your patients on 7th and 8th floor, or 6, 7, and 8, so you can actually come by, see your patients out there, and then sit back and then document and put everything, in the computer system, and have a game plan for all these folks, and then plan on discharges.
Yeah. Another one of our members had asked, what's the most enjoyable part about working at a hospital?
Oh, it's very challenging. I mean, I the most enjoyable part is actually kind of connecting with other folks, and meeting with, you have half your family, as they say, at your workplace. So it's good to learn how to communicate, connect with other folks. That's the big thing. Your social skills are really, really put to the test.
Mm-hmm.
And obviously, as a physician, it's an art. Your bedside manners, how you communicate with nurses, all that is it's very enticing and enjoyable. Like, people come in with different perceptions, and you are out there when you walk in, you're like, okay, this is what it is. I remember the time, like, I had to work in Virginia, and the family was all upset. Grandma's been here 15 days, and the nurses were telling me that family is going to be difficult, and I'm like, okay. And I was like, So let me go back and review the chart, make sure I know what I'm talking about before walking in. And I talked to the family, shook hands with everybody. There were like 14 of them in the room, uncles and cousins and everybody else. It's a big family. And 30 minutes later, I walk out, and I remember the nurses were asking me, were they ugly? And I was like, wow. For a second, I was like, no, not really. They were actually very nice. I communicated. I told them what the plan is, that grandma's sick and she's going to go to a nursing home. And so, again, the communication is important too. Uh, and I think building relationships, the recognition, and then they're like, "What's your last name?" And they couldn't, you pronounce it straight. So I'm like, "Just call me B. Dr. B is good." Okay. So once they get to know you, the challenges are out there initially, but you break those barriers. So it is quite a challenge. But yeah, that's the fun part. I mean, yeah, we do have a little doctor's lounge. You sit there and relax, and you have a 15-20 minute break in between folks, and you can plan your day the way you want it to go and flow. So there are days when you may not have lunch at 1 o'clock. It might be 4.
Yeah.
So yeah, that's the fun part. I think it's very challenging. I help other folks. I get a chance to talk to a lot of family members and communication, and this is a profession where you really have to communicate well, unless you want to be a radiologist and sit, in a in a dark room somewhere and just look at X-rays. It just depends on your personality. So you can pick and choose what you want.
That's something that our teacher always tells us. Like, even though this may be like a medical field and a medical profession, it's still like a customer service kind of role, because you're always seeing a bunch of patients and interacting with all the families and all of that.
And very true. And basically, at the end of the day, some of the insurance companies are now actually reimbursing the hospitals based on HCAP. It's called HCAP scores. So basically, they have a questionnaire to fill, just like when you go to a hotel. You're going to say, how was the concierge? How was the service at the front desk? Was the food good? Your hotel, your swimming pool, what can we do different? Same thing, the doctors, the nurses, the hospital, the food service, everything is graded. And I was talking to one of the patients that were actually filling out that little form right in front of me, and they were actually asking a question there, that did the physician and the nurse talk to you specifically about your problems, and were they able to communicate clearly and let you know what the problem was? Were you satisfied with the questions and what your plan is? Did they talk to you about discharge and who you're going to see once you leave the hospital? Did you get your wheelchair? Did they address your other problems? Pretty much, it's not like we're not McDonald's. You come and eat and get out. It doesn't work that way. We take care of the patient, and once you're getting discharged, what happens beyond that? Does grandma need a walker? Does she need a wheelchair? We will coordinate all that stuff. So they actually grade you based on that too. So the insurance companies reimburse hospitals based on their experience, and patients are the customers at the end of the day. It's a whole industry now. They call it healthcare industry. It's become a business, unfortunately. So.
I had another question. How did technology expand your field specifically, like the internal medicine field? Not healthcare in general, just like internal medicine as a focus.
I mean, it's like reinventing the wheel. The internet has sort of revamped, refurbished, and revolutionized a lot for physicians. I have access, every hospital doctor now has access to seeing a patient. Okay, I don't know what this rash is. It looks like it's something similar to what I may have seen. I can go into a computer system and say, this is what it looks like. This is the background. And we have not google.com. Okay, it's not Google University, because every time you walk in, the patients are like, I Google this, I Google that. So we have our specific medical websites, which are standard of care, and it kind of breaks it down for you, and the medications and the dosages and all that. So that has revolutionized us, where we're learning now from a data bank which is already there and easy access, which and the electronic medical records, EMR as they call it, electronic medical records, now tells us, if I want to if you come in with a sore throat and I put you on a penicillin, medication, immediately the computer system will pull it up and say allergies to penicillin. So I immediately know that I can put this medication in. because there's a risk that you may develop a side effect to it. And vaccines, stuff comes up like so and so's vaccine is due, and so and so needs this or that. The little pop-up reminders on the computer screen for every patient, especially medications, because we can sit here and talk all day, especially with taking care of patients, but if I don't put in the right medication, you're not going to see any results. So it boils down to what medications and what we're actually actively doing and how we can adjust dosages and make a positive outcome.
And in your field, are there any like procedures, or not really surgeries, but like any like outpatient or inpatient procedures that you perform specifically?
So when I worked in the ICU and basically as a hospitalist, yes, there are some hospitals where they require you to work and help in the ICU as well. So they do not have a pulmonary doctor or an intensivist. So we tend to put in central lines, deep lines, lines which are literally IV accesses in the neck or in the groin to help. It's not pretty much like a larger hose. You can give blood, IV fluids, medications as soon as possible to a septic, sick patient who could be potentially dying. And if there is, like you said, ACLS and codes and CPR and all that, we do all that, those procedures. All of us are ACLS certified, and we intubate, putting a tube down someone's throat and connecting them to a ventilator, which is pretty much what artificial respiratory ventilator respiratory system is as a backup. So yeah, those kind of procedures, yes. And biopsies and little skin procedures here and there, but no major surgeries and all that. If there is a potential to do any of those major surgeries, or if you need to do something, if it's a trauma situation, then you obviously have a subspecialty or a surgeon. So yeah, minor life-saving procedures would be pretty much ACLS and intubating somebody.
Earlier we mentioned that there's a bunch of people watching this live that want to be an internal medicine specialist. And what are some qualities that you would say a person should have when considering going into internal medicine?
It's I don't know. I think it's kind of different. I think this is a long drawn, dedicated process. So I think at the end of the day, you're either in it or you're not in it. There's no halfway. I've noticed that folks who actually, okay, let me try this kind of attitude or come in, and then maybe a year later in medicine, they're like, you know what, this is not really what I want. So I think you if you actually work, or actually these are your formative years, you're trying to get a grasp for that. Do I really like what I'm doing? Or do you see yourself, 15, 20 years doing this career? So the best way would be at this point, obviously in your teenage years, to actually shadow a doctor. You go to a hospital, you see what they're doing out there, and then you see their lifestyle, the way they communicate, they talk, their bedside manners, the diagnosis, what happens to a patient, what's the outcome, and all that, and see what their lifestyle is. I think that would be, interesting to you will actually sort of discover yourself more and get to know more about yourself than anybody else, because I think it's on a case by case basis. I can't just say, okay, it's not like, it's not like an athletic sport. You have to be 5'7" and you have to be able to run, and then you can be a doctor. It doesn't work that way. So there's no age barrier here. There's no height or weight barrier. No barriers at all. That's the amazing thing. So it's great. I mean, it's just a wide range of career options you got out there. The status, the salary, the security, all three things. And you can get a job anywhere. Listen, it's not just the United States. There are opportunities open in Canada. If you're trained in the US, you could practice as a physician in Australia and New Zealand too. The American and the British degrees are highly, highly recognized. That's why you find so many foreign grads coming in. I have a British and an American degree, so I love it. I get job opportunities. You could travel. You could go to Haiti and do doctors. You could join Doctors Without Borders, and pretty much go do stuff like that. You can go to Africa and do travel medicine. So there's a wide range of opportunities. Um, and so, yeah, I mean, what should you do? There's no clear cut, I think basically research, shadowing, watching some videos and seeing, how, what you like. I talked to a lot of young surgeons or medical students they're like, no, I'm not into internal medicine. I want to be a surgeon. I want to see, you know, immediate effects and go do surgery. Boom, within the next 3 hours you find a result. I want to see results ASAP. So speaking with counselors too, I think if you all have a counselor out there who can talk to you all about the career a little bit more, and reading up some magazines and knowing a little bit more about medicine and seeing what's out there. It's an ever-changing field. Every year, every 6 months, there's a new medication coming out. So that will kind of help guide you and mold you towards either you like it or you don't. There's no like, I'm a half doctor, that's dangerous, because then you can go kill somebody if you're not careful. So
yeah, I think that's why I really enjoy these sessions as well, because like our members and us as well get to like kind of get exposure to like different medical fields and kind of see what interests us more. So I think that's really great. Another one of our members had asked you about your education specifically. You specialize in internal medicine, but then you also have a background in infectious disease. So kind of how do those two play into each other?
Yeah, it was actually a marriage of. That's interesting, actually, because I know it was a marriage that wasn't supposed to happen. I started with a career of internal medicine, did a fellowship in infectious diseases, thinking that here I am going to do more of infectious diseases and have my clinic, which I did, outpatient, and had an 8 to 5 job. But I just felt I was seeing patients and doing, HIV, the regular, so we may be a developed country, but guess what? We also see, like I said, we have a lot of third world diseases. You see TB, you see malaria, you see a lot of infections, skin diseases, which you see overseas. I went to Haiti for like a month, and we saw 75 patients in the clinic out there, right from a dislocated shoulder to skin problems, and they don't have healthcare. There's like a little hut, and you're out there as a doctor with a stethoscope. That's all you get. You make a quick diagnosis and give them free medications. And so, yes, I started with internal medicine, did a fellowship, and then this was a marriage. Pretty much, if you have a good, sound background in your basic internal medicine, that's the platform, and then from there you can take off and do nephrology, rheumatology, infectious diseases, cardiology. You have to do a residency in internal medicine first, and then you do a subspecialty and go from there. You can't just go into cardiology straight away.
Yeah.
So I noticed that just doing ID, infectious diseases, I was just very focused into just taking care of only infections. I'm like, what about the heart? What about the other organs? I want a multitude of other problems too out here. And the patients would keep asking, okay, so I got, my back hurts. I got this hip problem too. And I was like, okay, I'm just so focused into just one field.
Mm-hmm.
Getting into a hospital, I had the opportunity of actually taking care of the whole patient, not just one disease or one problem. And I always thought at the end of the day, when I went home, you never regard the patient as a disease. You regard the patient as a person first. And that way I was communicating with the families and everybody else, and also the lifestyle. I wanted my 7 on or 8 on and 5 days off. I mean, which other profession can give you 5 days or 10 days off a month? Pretty much, I work half the year. Of course, I have a choice at this point. I go work at other hospitals too during some of the time which I get off. But most careers as a hospitalist, it's 7 on, 7 off.
Mm-hmm.
So you work 7 days on and you get 7 days off. And I know doctors who actually work 14 days straight, and the rest of the month is 14 days off. And they go travel. They go to Alaska. They go on a cruise. They go to India. They go overseas and just have a good work-life balance. People travel overseas and, go to the Caribbean and enjoy life. So you're working half the month, but you're full-time. So I don't see any other career doing that. No other job, so to speak. If you're full-time, working as outpatient, you really can't take that kind of time off unless you have 2 weeks paid vacation, which some contracts offer.
Mm-hmm. I remember we were talking about this beforehand, but like kind of managing both like your family life and your work life is difficult. So having like you were saying 7 on, 7 off definitely helps with that.
Oh yeah, absolutely. I mean, you come back and you're not a physician, and highly, at this point, I don't mean to sound sexist, but it's amazing how our women doctors manage their families. It's amazing. They wear different hats, and I often talk to them. And my fellow friend often tells me, she's like, "Hey, I manage a professional, personal, social, and family life, all four at the same time." I'm like, in 2 seconds, she takes her jacket off, and she's a mommy. She's not a doctor anymore. She comes home, takes care of her kids. I'm like, that's amazing. So you can do it. You have a good balance. Not that men, can manage all four, but once you get into a career out there, and you're expected to help, take care of your family, your kids, your career, and you have other opportunities too. I mean, your spare time, you can do other things. It's not all about medicine. It's not like, hey, you go to a hospital and it's just day in and day out just seeing sick folks. That's the wrong notion. You should definitely have a life outside medicine, because the burnout is so high. People get very, very easily depressed with the workload, the loans, the stress, the job, and the administration wanting you to see X amount of folks. You need to see 20 patients a day. So when you come back, you're exhausted. So you need some time to recharge. And, I highly encourage having a hobby, just going to, maybe a lake out there. You guys have, a bunch of lakes in the Georgia area and North Carolina. Just go out there, enjoy some time on the water, or do whatever outside, and have a sport or a hobby. There's things to do. That's a work-life balance. Work-life balance. That's so important too.
And you were mentioning how you spent some time in Haiti. Can you talk a little bit more about that? Because that seems...
Yeah, so that was part of the fellowship. It was, initially, so the fellowship initially wanted us, the fellows as they called us, we used to, in training, to go to a third world country, and actually do a little rotation of tropical medicine. And I had actually talked about either South Africa or maybe, Southeast Asia, but the distance was, way, literally traveling 15 hours. And they're like, okay, Haiti is close by, and relatively close by. It is the poorest nation in the Western Hemisphere. I mean, the average person out there makes anywhere from $2 to $3 a day. So it was a 2-week stint. We went there, we stayed at a church, and that's when we realized very quickly, a bunch of doctors, like, wow, this is amazing what we have back home. Here in the United States, you have 24 hours of water and power, and we didn't get that. We had to sleep on the floor in the church, and there was a little bathroom there, and pretty much you do your business in the woods out there. There was no bathroom, nothing. So we saw 60, 75 patients this lined up, and there was no proper transportation, nothing. You just get onto a little truck at the back, and with a little brick, you had to hit it, tap, as they call it, and they would stop and people would get off. So very third world-ish, which I saw, back in India, and I was like, wow. And certain areas are dangerous. There's a lot of crime. There's no police. So we lived in a church. We saw patients 8, 9 o'clock in the morning, all the way till 5, 6 o'clock, and with all medical issues. We got medications from the U.S. through permission, and we gave them free, right from skin, problems to worms and different things you see in third world countries. So yeah, we gave free medication and treatment through the church that they were affiliated with. So it's actually done on a regular basis, on a yearly basis. A lot of folks travel to Haiti or the Dominican Republic, or different South American or Caribbean, the countries in the Caribbean, and help out. Costa Rica or Nicaragua, those countries. So yeah, it was it was an eye opener. I mean, I felt very blessed when I came back. I'm like, here we have 5 different choices of toilet paper, and out there you had nothing. So we're very blessed.
So as you were talking about internal medicine earlier, you said it was a very unique field, and I just wanted to know, is it one of those fields where you have to keep on learning as you're going, or is it just a more set in stone thing? Because I know neurology is a keep on learning, because we keep discovering more and more over the years. Is it the same with internal medicine?
So the medical career, you're a student all your life. You can never know it all. I mean, there is so much out there. So you are a student and learning. Actually, I learn from medical students because there's a new medication out there and they're talking to me and they're like, hey, this just came out. So you are a student all your life. Yes, you have to learn and keep up, and you have your CMEs, you have your board certification every 10 years. Is the only profession for the most part, even lawyers, I think, and CPAs, you have to get a board certification every year. Sorry about that. So, and basically, take this exam and show that you're up to date on, your medical skills and even your clinical skills. So it is an exam done every 10 years. I just took it literally, so 2 years ago, and then again I have to recertify in the next 8 years. So yes, it is a learning experience. You are a student all your life. Yes.
So I think I wanted to ask is you as you're looking back on your career and all the different like environments you've worked on, is there some piece of advice that you want to give to your like undergraduate student self?
I think it's been very rewarding for me. Would I go back and do it again? Yeah, there've been days when I was like, you know what? I just want to quit, get a farm and raise some chickens and get away from all this. I felt that way too. So sometimes I'm like, wow, this is so overwhelming. But you do have that positive impact. You feel really well accomplished. It's rewarding. I mean, I just the whole wide range of people you meet, families, fellow, everybody has a story, how they got from where to where. It's like, hey, I started with this career, I switched. There was a guy who was an engineer. He quit and he wants to be a medical physician. And so like I said, it is this is a profession which has multiple subspecialties, and you can plan your lifestyle the way you want it. So if you don't like to see a lot of patients and deal with all that stuff, you could be a radiologist. You could be a radiologist or a pathologist just in a lab, have your 8 to 5 job. Or dermatology too is purely outpatient. There are no emergencies, so you can pick and choose. Your flavor of lifestyle, whatever you want. If you like emergency medicine, then be ready for it. It's going to be 12 hours of grueling, sick folks coming in right from gunshot injuries to a little abscess or a little toe infection or just a sore throat. But then the good thing is you work 12, 13 days in a month and you're good to go. And the rewards are good. I mean, it's a well-paying subspecialty specialty. It's well-paying, and you have a career out there for the rest of your life. There's no retirement in medicine. You can be 95 and practicing too if you're mentally capable of doing it. So
Just one more question.
Yeah.
So are there, like earlier you said, internal medicine, there's like multiple things wrong with the patient. I send them to the cardiologist and I also treat them. Are there are there specific occupations that you tend to see more in patients? Like, are there specific people you have to send the patients to? Most of the time, they're like very common. I hope that makes sense.
So depending on how common is common, so we're talking about the age group of folks, 18 onwards. So those are the kind of people I see. Anybody 18 and over. The younger folks, 18 to 30-ish, you're looking at, less chronic medical issues, fractures, motor vehicle accidents, stuff like that. The mid-age, diabetes, heart disease, older age, cancer, strokes. So that's how, you kind of grade it. You 20-year-old walks in, you're thinking, okay, this could be maybe just a motor vehicle accident or hopefully nothing very complicated. He's a young guy, he can pull through this, and it's probably just an infection, something out there. Maybe he hurt his toenail, it's a fracture infection or whatever you can deal with. 75-year-old is a smoker for many, many years. This is tobacco country where I'm working. Virginia, North Carolina, Tennessee, a lot of our folks here smoke and basically, have COPD and lung diseases. 42 million Americans have heart problems, literally. So that's a big one. You see a lot of heart issues with most of our patient group. So, that's the kind of folks. I see a lot of heart disease. I see a lot of cancers, and I see a lot of patients with diabetes and blood pressure issues. Yeah.
Okay. So
So
you see all different ages then.
18 and over, yeah. So we're about
Oh,
closer.
18 and
Yeah.
over.
So that's what
Okay. Yeah. Thank you.
All right.
Well, thank you so much, Dr. Baveja, for your time. To close out our event, we just want to thank you all for joining this conversation, all of our members, and for you making this very interactive and very interesting to learn about you and your career.
Well, thank you. Thank you for having me. Good luck to you guys.
Thank you.
Thanks a lot.
Thank you so much. So we are gonna leave the QR code up for like another 30 seconds. To get this credit, you must complete the form by January 25th. This video will also be posted on our YouTube channel. Thank you guys so much. Have a great night.
Thank you, guys.